Welcome back to Mic'd Up with Chiro. In today's episode, I had to bring in the man, the myth, and the legend, Tim.
Wow, that's something.
Now,
I'd like to meet him.
To be fair, we're still sorting out which one of those titles actually applies. But I figure I'll give them all three and let you, the listener, decide. Either way, he showed up. Hopefully he has some great insights. So let's kind of jump into this podcast quickly. I've got three topics that I think between him and I, we're going to shed a little bit of light on, and not just random research, not just random things in the software, but things that are actually going to impact your practice. In the next 30 minutes, Tim and I are going to wade through some new research on diaphragmatic breathing and chronic lower back pain. Then we're going to dig in a new report, new functionality we have in the EHR to kind of guide you through some small incremental changes in your habits that you can have that really have already had a dramatic impact on our practice and really our profit loss statement. And finally, to round out the podcast, a seasonal clinical finding. And I'm going to bring up why flip-flops are a chiropractor's dream shoe. Sounds kind of weird, but we'll discuss that at the very end.
Can hardly wait.
Well, stick with us through the whole conversation because each section is going to build on each other. We're going to give you practical ideas you can apply with patients right away. And if you find any kind of value in the discussions, do us a favor. Share this episode with a colleague or a friend in the profession so we can keep getting great clinical insights in the hands of chiropractors everywhere. Well, to get into it, Tim, it's great to see you again. Obviously, we practice a 2x4 wall away from each other in practice, but really it's been about a week since we've had a time to sit down after getting back from Parker and get in the swing of things back at the office.
Yeah, thanks for the heartfelt introduction. Parker was awesome. You kicked things off, and I was blown away that there was such a line of people, not for your class, there was such a line of people that were waiting to get in. I'm like, oh, nobody's going to be in here. But then your class overflowed. It was standing room only. I thought it was a really good class. One of the big bonuses is about 10 of us woke up after the class, and we actually had been there for 2 hours instead of one. No one else was in the room. So we got extra CE. Thank you.
Look at that. Look what I did for you.
Yeah, you're always helpful. Value-added services.
Well, I'm glad you brought up Parker. I actually got dragged into a lecture at Parker. We'll just say it's an unnamed speaker, but for the sake of anonymity, let's just call him Ben Turtlesman. He was talking about the fascinating diagnosis of spinal instability. And I mean this truthfully, that this is actually a tricky category for chiropractors because our default tool or treatment is manipulation. We're going to restore mobility. However, instability needs the opposite. It needs stability. So what caught my attention in this talk is that diaphragmatic breathing aligns perfectly. The way you deliver the way Dr. Turtlesman, sorry, not you.
There went the anonymity.
We had just released a paper in February 2026 about this, and it was a systematic review of randomized control studies looking at breathing-based rehab for chronic low back pain. Now, back pain and breathing, what's the connection there? And there's a lot of techniques like DNS that look at this and PRI. However, we have to understand this as a provider, regardless of your training, to make sure that we know how to assess for diaphragm function, how to use diaphragm work as far as manual therapy, so we can improve both pain scores and disability scores with this patient population. Now, the theory makes sense. The diaphragm is not just a breathing muscle. It is a spinal stabilizer. It's going to create that intra-abdominal pressure, or can you create that intra-abdominal pressure? And when the system isn't working, unfortunately, the spine tries to stabilize itself in different ways. So, Dr. Turtlesman, what were your takeaway points? During that conversation, I thought it was interesting how you covered all the things that we can do to a patient, but one of those specifically, even for back pain, was looking at the diaphragm.
Yeah, I think for me, it's just the understanding of kind of dumbing it down for myself that we treat patients who have issues with their spine. Their lumbar spine is number one. And if I think of that lumbar spine like a spring that has a very weak link in it that it's ready to break, that's our patient who may have a joint dysfunction or a disc lesion or a spondylolysis or whatever it may be. They've got a weak spring, and that's encased in a canister. Think of that like a soda can. So you take this weak spring that's almost ready to break, put it in a soda can. If it were sealed, you and I could torque on that can, and we're not going to impart enough energy to the spring to harm it. But if we would simply open that can, now when we torque on it, we're going to be able to harm the spring. And that's what our patients are coming in with. They've got these powerful robotic arms, their arms and their legs, that are mounted to some canister. And the more stable that canister is, the better. Just like any robotic arm, if it were mounted to a steel frame, you're going to pitch a baseball more accurately and faster. You're going to have more power. You're going to be more accurate. If you mount it to a block of foam, it's going to be very unstable. And the transition from that steel canister into a foam canister and vice versa is dependent upon our ability to pressurize the abdomen. Lots of things compromise that. That sometimes we're, sucking our belly in. That's not creating stability. Sometimes we have somebody living in our belly. Other times we have sitting at a workstation. And if the floor of that canister and the roof of that canister, meaning the pelvic floor and the diaphragm, aren't parallel, it's very hard to create good pressurization. So determining, is somebody doing something that they're not going to be having a stable canister? And the biggest one of that is dysfunctional breathing. That instead of breathing from their belly and expanding their lower ribs, they're breathing from their chest. And that's okay. You can breathe from your chest if you've been running down the beach or running from a bear. But if you've not been doing that, you probably should be breathing from your belly. And that's what's going to keep that canister pressurized. That if your diaphragm isn't engaged on a regular basis, we're going to have a leak, and that's when the spring gets damaged. So the talk, I thought the most useful part for me was learning which exercises are most appropriate. We're going to give that patient some breathing exercises to see, how do we teach them to breathe from their belly. Put a hand on your chest, a hand on your belly, and when you take a breath, move just the one on your belly. And then giving them some core stability exercises, because those go hand in hand. So McGill's Big Three: a dead bug and a bird dog and a side bridge. And we went through all of those exercises as well. If you didn't make the talk and you'd like to check that out, we have a webinar, if you go to the ChiroUp homepage, on spinal stability and dysfunctional breathing. And also, if you're a user, you can just go in app for a much better resource and look at the segmental instability or the dysfunctional breathing protocol. It'll have all the appropriate assessments, including how to look at that breathing and what exercises we might do and how to deliver that to a patient.
Yeah, it really was a good talk. And the interesting part about the Parker seminars nowadays is that it is a wide range of providers and talks that you see there. The gamut of people that you can see as influencers in the profession, and that was one of the most well-attended talks. So good job on that.
Well, shout out to Parker. They attract a great crowd. That is a premier event in our profession. If you haven't gone in the past, and we have no loyalty to Parker other than they just do a great job at anything they do.
No, they said we get $5 every time we mention their name, right?
Yeah, Parker. So everything they do is first class, and this seminar was no less. The talks that they had, the vendor areas, every aspect of it. If you haven't been there, check it out.
To round out or end that conversation in the podcast, I think that one of the most interesting parts about that talk was the multimodal fashion that is required to treat most diagnoses. So when you're treating, chronic pain, what are all the things you can use? Whether it's, it could be even, nutritional supplements, to advice, to breathing exercises, to manipulation. And it kind of rounds into the next section that those are all called service codes. And it's a really interesting thing that happens in chiropractic practice, that as a provider, I'm really focused on getting people out of pain, solving their problems, whatever it may be. And my office is so focused on, getting that person out the door, keeping everybody happy, that sometimes we need to take a retroactive look to see what happened. And a new report was released in ChiroUp called the Service Code Usage Report. And this is a really funny report, and I'm going to kind of expose some of my ignorance here, is that after 15 years in practice, we've never really looked at this.
Right.
And not that that's a good thing, because now that we have it, now that I can really look at I'll call it my chiropractic billing pattern, now I can actually learn from the data, and I can see why this is so important. And it was requested, we'll say, to create this report. And I think that one of the things that we stood on, or one of the things that we created, one of our mission and our vision as a company, is to take things that our subscribers need and turn into reality with this case coding. But to do that, we needed some kind of conduit to get the opinions and the wants and the needs of our chiropractors into our hands so we can design that functionality for them. So before we dive into the service code usage report, Tim, can you describe how that happens with a process or a program that we call ChiroUp Vote?
Yeah, Care Upvote, really it's inherent to what we want to say. This is why we're different. That we didn't want to create just one more system. We wanted one that leveraged the support team that we had. We know one of the things that makes Care Up unique is the support. In fact, we just had our planning meeting this morning and saw the statistics that the average onboarding satisfaction score is 8.5 out of 10. The average time to resolution for an issue or addressing the issue is 3 hours, 3 business hours. So they're doing a great job there. We also have the fastest meaningful note. And then the third thing related to your question is we created a chiro from inside the profession, that this wasn't something that was retrofitted by another profession to fit chiropractic just because we wanted to collect dollars from it. This was something to advance a mission to make our profession the undeniable best choice. And that means that it had to be crowdsourced. We had to listen to our subscribers. We started with focus groups. And Chiro Upvote is the next evolution of that. Now that the product is up, running, and extremely stable, now we want to know, how do we make it even better? So users, whether it be the doctor or their team, can suggest, hey, what if you did this? And then other users can vote on that. They can comment on it. It's a really easy platform. If you've not used it, you can jump into the support hub and it's there. And then that's how we determine what to code. That's become our new prioritization list. In fact, the things that are in coding right now, like we're developing in-office chat. Think of like a Microsoft Teams type process. We're testing that, and that'll be available for all subscribers shortly. And we'll have document storage available for all subscribers as well. Maybe you want to put in your insurance information into the chart. And then one of the big things that I'm super excited that we just got today in our alpha testing clinic is a recall system. We all know how staff hates to do recalls, but it's one of the most important things for cash flow, that if you lose a patient, you may as well have given an employee a bank bag that had $500 and they lost it on the way to the bank for every recall they drop. So the recall system just automates that process with customizable messages, makes each one quick, and those things are happening solely because of Chiro Upvote. You telling us, here's what we need in the system.
Yeah, it's all exciting functionality. But getting back to the service code usage report,
which was one of those things that came out of Chiro Upvote.
Exactly. As building this, we saw value in it, but we didn't think it would be that valuable until we started getting more and more votes. I'm like, oh, well, this is something that would be valuable not only to us, but also to the people we serve. And we did this as let's call it an internal review of a random clinic. We'll just say that. And we looked at all the 989 codes that we could be using just to get a better understanding of our coding habits. And here's the question that I was really trying to answer for myself. Are we undercoding or are we overcoding? And I think both of those could be a problem. So we're going to discuss that right now, because what it looks like from this mythical clinic is that we heavily rely on 98941. So in our data set, we were higher than normal, I'll just say, for spinal manipulation for 3 to 4 regions. Now, this is the most common code that is billed in chiropractic practice. When you look at national Medicare utilization data, between 60 and 65% of all claims have this code. It drops down to 25 to 30% for the 98940, and then for 98942, it gets into the 5 to 10%. Now, here's the lesson that I learned, is that that's the normal. And what we know is that you can get audited if you're outside that normal, but that doesn't make it right or wrong. So what they really care about, or what I care about, that we're going to discuss further in the next section, is that yes, we could fall outside that range, but what is the most important piece does your documentation match your bill? Think about that. Well, of course the answer should be yes, but does it? And does your software, does your biller, does whoever is in charge of your billing, do they have eyes on it? Because if you have the exact regions you're treating, if you document, hey, here's the treatment because I'm treating this area because of their chief complaint, and we document why we're doing what we're doing, then you are justified. But we need to have all those things to make sure that if we are following out, or we're falling outside of the trend, outside of that standard deviation of normal, we need to have the proper documentation. So to get to that long introduction, we found that one of our providers was billing something that the other ones weren't billing hardly at all. Tim, since it was you, let's talk about it.
Yeah, so the reason 98941 was slightly above average is because none of us were billing 98942. that utilization was slightly below 1%, closer to zero. And one of the things that I saw over the last few months was when I'm using the software, it will help me to auto-populate what code is appropriate based upon how many regions did I indicate that there were issues. And in the past, my utilization of 98942 was 0% as well. And then the system started suggesting, hey, you've got 5 regions here, you've documented enough segments, you've documented enough muscle issues, your orthopedic exam is there, why aren't you billing this? And for a while, I was just continued to downcode it. Now I'm going to move this to 98943 as I've done to 0 rather, as I've done my whole life. And I decided to stop doing that. So now that I'm not doing that I keep it when it's appropriate, I've gone up to more like the 5 to 6%. So it's still on the low end of normal, but that 5 to 6% is a lot different than 0%, especially because the reimbursement is different. So I've quit downcoding. I've started using the codes appropriately, and hopefully that spills over to other people as well.
And that's the point that I really want to make in this, is not that someone's doing it right or someone's doing it wrong. It's that, does your documentation match your bill? And it sounds like it's so easy. And of course, we have to make sure that we have, the part diagnosis, our pain and asymmetry and range of motion and tissue tone when it comes to spinal manipulation. And that's the Medicare rules. I guess it really doesn't fall into the 98942, since that's not, 98943, since we're not going to bill that for Medicare with an extremity, but everything else it does. So I keep things compliant and standardized for all my billing. And then of course, we want to designate active versus maintenance care. However, the key piece to this is you can bill higher level codes, but if you don't have the documentation, that's risky. You can fall outside the standard deviation. However, if the documentation doesn't match, it's risky. Make sure your documentation matches your claim. Now, finally, the fun stuff. So earlier in their episode, I hinted at flip-flops might actually be a chiropractor's best friend because of what time it is. And so I know you can listen to a podcast anytime, but right now it's March in St. Louis and spring is rolling around. And I think that this is one of the most interesting things that I see in practice, is that when people start wearing flip-flops, plantar fasciitis starts to show up. It's kind of like peanut butter and jelly when I think about it. Every year when the weather warms up, clinics are seeing a wave of patients with a multitude of issues, but let's just talk about heel pain, because it seems like overnight, on Monday, on Tuesday, we start to see these conditions start to present. And instead of just talking about plantar fasciitis, I want to zoom out just a little bit, because people don't magically get plantar fasciitis. There's no plantar fasciitis fairy. What actually caused the overload of tissue? So we'll discuss the etiology, some treatment ideas, but most importantly for this podcast, how footwear influences foot biomechanics and why shoes tend to trigger problems like plantar fasciitis. And how can we, as chiropractors, as the person that's going to solve this problem, how can we help our patients make better footwear choices in the first place, so we can, one, get them out of their pain, but hopefully prevent it from ever happening again. And we're going to talk a little bit about shoe design. We're going to talk a little bit about foot mechanics, and then hopefully give you some practical pearls that now you can use your patients right away. Tim, this is why I brought you in this podcast. Your expertise in lower extremity fits in well here. See, you are useful at certain times. Let's talk a little bit to start off with what is the plantar fascia, and then how can you explain its action, not only for our listeners, but how can they explain what the plantar fascia is to their patients?
It's lunchtime. I'm still kind of hung up on that flip-flop and peanut butter and jelly thing.
Should I talk louder?
Quieter might be better. But we all know what the plantar fascia is. It's just that dense piece of gristle that lives on the bottom of the foot. It's a stabilizer. It's a protector of all the neurovascular structures. It comes off of the bottom of the calcaneus, especially more so the medial side, and then goes down into the toes. And its purpose is to help the foot pronate, to help the foot change from this flexible shock absorber into a rigid lever. And that happens through the process of toeing off, and that's via the windlass mechanism. That if you think of that fascia, it's going off of the heel, it's coming over the metatarsals and over the distal joints onto the toes, and when your toes go into dorsiflexion, it's going to wrap that fascia around the knuckles, which is going to tighten or shorten that band, which is going to force some degree of pronation of the foot. And that's what changes the foot into that rigid lever. So when we're running, we'd like to really step down with a flexible shock absorber. When we take off, we want to have a rigid lever, just the same way you'd want to hit a baseball with a stiff bat to preserve that energy and momentum. So during propulsion, that dorsiflexion of the toes winds that fascia around the metatarsal heads. That elevates the arch, and now we can push off. A lot of times we thought of plantar fasciitis as an itis, but now the more recent studies say maybe not. Maybe it's more like tendons, where this is turning into degenerative tissue rather than inflammatory. And we're getting a lack of inflammation in the area. So that explains why anti-inflammatory treatments didn't often work in the past, certainly not for tendons and often not for plantar fascia, whereas mechanical treatments work better. If we can stimulate a controlled inflammatory reaction and correct the underlying biomechanical faults, better things happen. So these patients need inflammation and progressive loading. They don't need more rest and steroids and frozen water bottles.
Yeah, I agree. And this is one of the things that I think is an interesting scenario that happens in my practice, is that what happens...
That your patients come to see me when they fail?
That they come back. It is kind of interesting how you can physically and psychologically harass a person, but if you make them feel better afterward, they still come back and pay you.
But or work with you for 15 years.
What do you do when a patient already went to another provider and had their plantar fascia cut, or had a steroid already, they're already taking a steroid, had an injection? That's a tough conversation. I have a preceptor right now, and he was intrigued by the fact that I always say great. And he's like, well, what do you mean great? Like if they come in and said, I just took an epidural steroid injection, I say, great, let's see how that works. And then I'll see you again in 2 weeks, and if the pain is still there, then let's get down to treating it. Because if I say, oh, we shouldn't have done that, well, then it creates a sense of doubt. And I don't want to ever go back on what another professional is doing. However, with that being said, I see this a lot. I already had a steroid. I already had 3 steroids. Now the podiatrist wants to cut my plantar fascia. And I'm not saying that's a bad procedure, but for run-of-the-mill plantar fasciitis,
that's a bad procedure.
That's a bad procedure. So we want to make sure that we keep the patient knowledgeable in what else can we do for the patient. And one of those is to stop resting it, stop relaxing it, stop rolling on a foam water bottle, and let's get down to treating this. Now, who gets affected by plantar fasciitis? And what we know, it is a smaller population, about 10% of the population. However, of all the foot issues, it is a quarter of all foot injuries. So it's a big deal. It's really going to come down to one thing. Is the person doing too much and not getting enough rest? So are you exceeding the capacity of that tissue? And unfortunately, there are certain mechanics, certain structures that will lead someone into having this problem more than other people. So arch mechanics is probably the number one. It's kind of easy to, it's kind of low-hanging fruit. Unfortunately, we can't say that all people with flat feet are going to have plantar fasciitis. While it will increase the tension of the plantar fascia, it doesn't mean they're going to have plantar fasciitis. They're just at an increased risk. Now, the same can be for a high arch or pes catus. So when you don't have an arch that's going to collapse, you are going to put a lot more force and impact force on a plantar fascia. So both of these foot types are going to be susceptible. We need to put the person in the proper shoe to accommodate this foot structure. Also, think about the back part of your leg, the posterior chain, the gastroc, the soleus. These, unfortunately, are going to pay a price, because what happens is when you have plantar fascial pain, you don't want to go through full ankle motion, plantar flexion and dorsiflexion. So the muscles that are responsible for that tend to get tighter and tighter and tighter. And what we know is that people with plantar fasciitis are 9 times more likely to exhibit hamstrings tightness, which is, of course, a part of that posterior chain. So those are things that I look at. Also, less fixable in the short term, I'll say, is body mass. Unfortunately, BMI, when it gets above 35, they are more likely to have plantar fasciitis. In fact, 2.5 times more likely. It's just more stress going through the same tissue. And then we also can have systemic issues like cholesterol issues, systemic inflammatory markers, and autoimmune problems that unfortunately will lead to an increased incidence of plantar fascial pain. So we do want to have an overview of their metabolic health. If that doesn't fit into your practice style, that's fine. Find someone in your area or find another chiro who does functional medicine that you can refer your patients to.
Yeah, and looking at their activity load too, we know that plantar fascia has a lot of load during locomotion. That when you're walking about 2,300 steps per mile, running not quite as many steps, but a lot more force, that up to 7 times body weight when you push toe off when you're running. And that's why symptoms are often appearing after patients are walking or running, especially if they break the 10% rule, more than 10% increase in activity. So sudden increases in training. If they're on harder surfaces, especially concrete, that makes a difference. And seasonal changes too. We know that plantar fasciitis is going to become more popular about right now when there are more hours in the day, and it will become more popular in the fall when people transition off of soft outdoor surfaces like soccer fields and football fields onto basketball courts and volleyball courts. We also know what it looks like. These are the patients that come in when I step out of bed in the morning. It feels like somebody stabbed me in the foot with a knife or a tack. The first couple of steps, and that's because the plantar fascia gets stressed throughout the day. It begins to fray away, if you will, from the calcaneus, and then at nighttime your arch springs back up. There's no load. It heals in this shortened state, and you step down in the morning and teach the plantar fascia it needs to be longer. The plantar fascia doesn't agree. It's not quite ready for that, so it screams. And those symptoms that we see throughout the day is pain, especially during the push-off. When you use that windlass mechanism, when you wrap that fascia around those metatarsal heads, there's going to be discomfort. It feels better when you sit down. It feels better after you've been mobile for a while. And then when you go to sit and get back up, it's going to hurt again. So one of the classic tests is just to reproduce that, the windlass test. You dorsiflex the toes. It can be either the great toe or all the toes. And then palpate the fascia and say, does that reproduce pain, either just by dorsiflexing the toes or by palpating the fascia? Did the tenderness get more intense when I put you in the windlass mechanism? And this is a huge differentiator for the other possibilities. We want to think that heel pad syndrome or a stress fracture of the calcaneus can look similar to plantar fasciitis. The windlass test can differentiate that. Walk on your toes. If it hurts more, it's plantar fasciitis. It's definitely not a heel pad syndrome or stress fracture. And then the other one we think about is Baxter's neuropathy, which is irritation of a branch of the posterior tibial nerve that supplies the heel, and so it has symptoms right in that same plantar fascia area, but it also supplies a little muscle on the outside of your foot called the abductor digiti minimi. And when you have Baxter's neuropathy, here's a clinical pearl. If your plantar fascia patient isn't getting better after a few treatments, try to have them abduct all 5 toes against your resistance. And if that little toe doesn't shoot out, there's weakness of the abductor digiti minimi, and it's probably Baxter's neuropathy. If you want to deep dive into that, go into the Chiro-Up condition reference on Baxter's neuropathy. You'll be able to see all of the tests and treatments associated with it, because this is present in up to 20% of our plantar fascia patients.
It's so funny whenever we do a condition reference or a blog on the obscure, they're always the most common. It's like, well, what is that? And it's interesting because they're often a lot more common than we think. We just keep on misdiagnosing it. I know when I first started, I never diagnosed thoracic outlet syndrome. Wasn't that I didn't see it, it's just that I didn't recognize it. So just to be cognizant of that, so many chiropractors that I talk to are in the business of seeing patients. They don't want to release those patients. They want to see them for life. And that's great. I want to see all my patients for life also. But I think the way that we're going to see a patient for life is if we get really good at treating all the different diagnoses.
Yeah.
If I'm treating plantar fasciitis for 20 years, we got a problem. Someone's got a problem. So we need to get to the right diagnosis fast. Now, the purpose of this podcast, the reason I get excited is because I love looking for the etiology. And it's not...
I thought it was because we got to hang out together.
It's
different excitement.
Exactly.
Yeah, I could see it on your face.
Emotionally excited.
It's just, oozing out.
I'd rather talk about footwear, to be honest with you.
Here's a Kleenex.
Footwear is important, though. And I think that's one of the most interesting things is that the Nikes you buy at Kohl's and Nikes you buy at a running store are actually 2 different types of Nikes. And I think that footwear plays a significant role in either causing or preventing you from getting plantar fasciitis back to normal. And I think that's something that we can focus on today. And traditionally, I was really focused on the 4 major types of shoes.
Yeah, and I know you mentioned these. I'm gonna grill you on the spot, though. The first one would be a neutral shoe. What is a neutral shoe?
It's the most common shoe. So a neutral shoe is for natural foot motion. It doesn't have anything else built in. It has a flexible midsole. It's uniform cushioning. It's the shoe that you see at the bottom. It's all white all the way around. It doesn't have any plastic, doesn't have any other colors that have different durometer foam.
So a little flexible. And who would benefit from this shoe?
This would be your people that really don't have any issues. They have normal arches, they have efficient gait patterns, and they're probably not coming into your office for a foot problem.
So a fairly normal person wears a neutral shoe. Next one you have is a cushioned shoe. What's that? Cushioned wear?
Well, these are going to be for people that need some more shock absorption. So people who need a thicker midsole, a higher stack height. So more white foam at the bottom of their shoe, essentially. And that cushioning is soft energy absorbing materials like an EVA. And it's going to be for those people that have a higher arch, because those people aren't able to dissipate force as well, and their foot stays in a more supinated position. And what I always say is that, listen, if you get out of your pool and you start to walk across the concrete, do you pretty much only see your heel and your metatarsals, or do you see your whole foot? If you see your whole foot touching the ground, you've got a flat arch. If you only see the heel and the toes, well, you normally we're going to have a supinated foot.
All right. So somebody who has a high arch or supination gets a cushioned shoe. If you have a normal arch, you get a neutral shoe. Who gets a stability shoe? What is a stability shoe, first of all?
These are designed to control moderate pronation. So they actually have some either a different density foam, but more likely some plastic in their medial arch. And this is going to create a firmer midfoot. So it's going to reduce plantar fascial tension by supporting that medial longitudinal arch. And it's going to essentially put more of their foot on the ground and, to distribute plantar pressure a little more evenly.
So if you start to have a little bit excessive pronation, something to stabilize it would be helpful.
Yeah.
And then finally, motion control. I can probably guess where this is headed.
Even you can figure this one out. It's going to control motion. It's going to do a little bit different. It's still going to have that rigid midsole, but it's going to have a strong heel counter, and it's going to have significant medial support. And from the research, it does control pronation, but really it's about slowing down the rate of pronation. So for those individuals who have severe overpronation or really flat feet, this is going to help them avoid over-tensioning that plantar fascia.
And isn't the rate of pronation more related to foot injuries and problems like this than anything?
From the research I've read, I think the answer is yes.
Yeah, I thought you had mentioned that before. I thought that was interesting. All right, a couple more questions to shoot. I know we talk about other variables, not just the type of shoe, but some more newer metrics like heel to toe drop, which is basically the pitch of the shoe. So we'd be saying if the heel is 30 millimeters high and the toe is 20 millimeters high, we have a drop of 10.
Whoa. There's no math in chiropractic.
Trying to keep it simple. So there are shoes with really high heel to toe drops, like the Nike Air Zoom Pegasus, the Asics Gel Nimbus, the Brooks Ghost. And then that drops all the way down to very little heel to toe drop, like the Ultra Torin 7. What do we need to know about that?
Yeah, and I think a lot less companies are doing those zero drops. I know Brooks used to make their Pure line as a zero drop. They don't make those anymore. However, I will say this, is that I got a chance to meet the rep from Ultra. They really do a good job, not only with their shoes, of course, but also supporting profession. And not as known of a shoe, but I would highly look into that type of shoe if you're looking for a zero drop shoe. Once again, not a paid speaker. We have no affiliation. Just a really well-built shoe. But these lower drop shoes do one thing specifically, is they require you to use all your joints, which sounds like a great idea. However, if you're used to being in a New Balance with a really high ramp angle, and you go to a zero drop shoe, it's going to force some more ankle dorsiflexion. It's going to force some more great toe dorsiflexion, which you need about 70 degrees. But if you look at your average person who's coming in your office, they don't get anywhere near 70 degrees. And if you're not getting adequate motion at the great toe or the ankle, that midfoot is going to pay the price. So I love zero drop shoes. However, if someone doesn't have good foot biomechanics, we don't want to abruptly go from a normal shoe, to a zero drop shoe. This is going to create injuries as compared to help. And unfortunately, these higher drop shoes, like most of your New Balance, where it's a really big heel, that's okay, and they're going to take tension off the posterior chain. They're going to take tension off the plantar fascia, off the gastroc, and off the soleus, and off the hamstring. That's okay, but unfortunately, you're going to rob Peter to pay Paul, because it is going to put increased stress now with the knee. So we really kind of want to make sure that we know the biomechanical result of switching the types of shoes.
Well, that's useful. The other thing that I have a question about is the stiffness of a shoe. I know that we can go from anything that's flexible all the way to relatively stiff shoes. How does that play into it?
Well, this was my favorite blog that I ever wrote. It was,
I've never seen a favorite blog that you had written, but
it was a favorite of mine.
oh,
It was on the marathon runners, and I'm sure my stats are wrong. This was a couple of years ago. However, marathon runners, the winner of the Boston Marathon had the exact same shoe, not the exact same shoe, but the same type of shoe. They all wore the Nike Vaporfly Next, and clearly a good shoe. But why? Why are all these runners choosing this shoe? Well, it turns out that midsole stiffness is related to what materials you put in the midsole. And there are certain shoes like the Nike Vaporfly, the Saucony Endorphin Pro, the Hoka Rocket. These are all things that put carbon fiber in that insole and actually returns energy back to the runner. So it's essentially a spring. Most shoes are going to have some kind of TPU, some kind of hard plastic. It's going to increase stiffness. It is going to have a little bit of energy return, but not like a spring. So if you have midsole stiffness, and that's something you care about, it can actually help your plantar fascia, and it can help you move through the gait cycle faster.
A little added stiffness to the foot.
Mm-hmm.
And then finally, last one, as though those two weren't enough, to think about rocker sole geometry. This is basically the curve of the shoe, right? The curve between the foot and the heel. What do we need to know about that?
And this is often abused sometimes with your really big Hokas that have a really big sole and a rocker bottom, or you just have running shoes with just a rocker bottom. So when we talk about just a rocker bottom, this is going to reduce the range of motion you actually need in the metatarsal phalangeal joints. It's going to reduce the amount of tension in the plantar fascia because you're actually taking some of that dorsiflexion out of your ankle and out of your toe and putting it towards the shoe. So, and once again, none of these are bad. There's not a negative shoe in here. There's not a specific shoe that's great for everybody. It's dependent on the person. So when someone comes in and says that I've got the best exercise for back pain, you and I chuckle a little bit, right? And even you chuckle there. You're like, well, it's kind of different exercise for different people. But if you get on YouTube, there are the best exercise for everything. I can cure all, a frozen shoulder in one exercise. Well, that's not true. And the same thing with shoes is it doesn't mean rocker soles are good or bad, or carbon fiber midsoles are good or bad. It depends on what your patient needs. So if someone does have reduction in dorsiflexion of the great toe, well, maybe a rocker bottom is a good idea to get around that structural deficit. Now, let's talk about how to treat plantar fasciitis. What are the things that we can quickly go through to help our patients get out of pain if they do develop this condition?
Yeah, the good news is or bad news, whichever way you look at it, there's lots of people who suffer with plantar fascia problems because they chose the wrong shoe, because they had the factors that made them at risk, or because they overdid it. And we know that almost half of those patients who complain of plantar fasciitis have similar symptoms 10 years later. We know that using a multimodal approach is the key. We certainly want to stretch out the posterior chain, especially the gastroc and soleus. When it's tight, if it's not going to give, think of two springs. One's the plantar fascia, one's your gastroc and soleus. If one spring is inflexible, the other one has to give more, and the plantar fascia doesn't have anything extra to give. So stretching out the gastroc and soleus. Also making sure that we're strengthening the intrinsic muscles of the foot, things like toe curls and gripping exercises, as well as strengthening the posterior tibialis to help hold up the arch of the foot, make your own intrinsic arch support. Our manual therapy to work out the muscles that are tight, and also to release any irritation in that posterior tibial nerve that may have been irritated from chronic pronation, because remember, it's getting stretched when the arch falls, and then certainly stretching out and stripping the arch, whether we do that with our factor tools or our Graston tools or whatever we may want to use to work that out. Patients often need, at a minimum, counseling on what type of an arch to put in, like get one back in there, all the way up to custom orthotics to help support that. When they have an arch or an orthotic in, it prevents that pronation. It keeps the stretch off the plantar fascia. And then finally, modifying their activity. If they're still overdoing it, they probably need to take a break. One of the things that I know we talked last time about our Shockwave machine, Shockwave has tons of research and anecdotal evidence as well to say that it works great for tendinopathies. And I think probably number 2 is plantar fascia. That getting some blood flowing to the area, getting some fibroblastic activity and tissue repair makes a huge difference. And then finally, making sure our patients know to replace worn footwear. When running shoes start to break down, they lose half of their shock absorption in 300 to 500 miles. And any runner can tell you, your shoe still looks great, but it's shot. Minimize your time walking barefoot and make sure you're rotating your shoes. Not necessarily different shoes, but you might have a couple of different pair of shoes.
Yeah, it's an interesting topic. We just started marketing to podiatrists for the Shockwave machine and have some really good clinical results. And of course, just building our practice for other associates and having another line of service. Before we wrap things up, let's bring things full circle. Today we covered a lot of ground, actually. We started talking about diaphragmatic breathing, chronic lower back pain. We talked about a couple clinical nuggets that came out of Parker Vegas. We took let's call it a quick detour in some small operational changes in our EHR and how it's going to hopefully incrementally reshape our yearly P&L for our clinic. And then finish with some seasonal reminders that flip-flops are just possibly our favorite shoes. Not bad in 30, no, we're at 40 minutes now. However, as always, I love these conversations. We love talking about research and ideas. Hopefully you can incorporate some of these practical things in your clinic today or tomorrow, just to make your patient care a little better, your clinical thinking just a little sharper, and maybe even just practice a little smoother. And of course, thanks, Tim, the man, the myth, the legend. I guess at this point now we can figure out which one he is.
More myth.
And thanks for spending 40 minutes of your time with Mike Debacaro. Two asks for you. One, I think we're going to do it in 2026. I haven't talked to you yet about Tim. He's looking at me. He's like, why are you ending the podcast with something new that we didn't talk about? But we are going to be incorporating some guests. We have gone all these years without doing it, and we really have kind of focused just on the software and focused on the clinical and the research. But it's that time that people are telling us they want to stop hearing from us is really what it's coming down to.
Well, I see where this is headed.
So my job this year is to replace Tim and find some more interesting people. So my ask is this: email me. If you have my number, text me. If you want to hear from somebody, let me know. I'll try to get them on the podcast. And until next time, we're going to keep on learning. We're going to keep on testing ideas. Send me that email. I'm going to see if I can get some legends, some influencers, some people that you guys want to hear from on some topics you want to hear from, and to make this podcast even better in 2026. Thank you.